Hello, my name is Annette Dobbs, and I will be performing my physical assessment, including the eyes, the nose, the mouth, the thorax, and the cardiac system. Starting off, we're going to look at the optic nerve. This is cranial nerve number 2. And with this, we would use a Snellen chart. A Snellen chart is the big chart with the E that's on the wall, 20 foot away from our client. And we would ask the client to sit or stand, whichever one they are more comfortable with. And they would read this chart top to bottom, left to right, down to the smallest line they're able to visualize. We would do this if they did have corrective lenses with or without the lenses, and they would cover one eye, read the chart, cover the other eye, read the chart, and then visualize the chart without covering their eyes. This test for farsighted vision and the reading for a perfect score would be 20/20. Each line has a scoring on the side in the form of a fraction, and in order to get credit for that fraction of that line, they would need to be able to visualize more than half of the letters within the line. And they would read that line. The top number is how far away we are from the chart, which would be 20 foot, and the bottom number is how far a person with perfect vision would be able to visualize that chart. The second test we would do for the optic nerve is the Rosenbaum test. With this is testing nearsighted vision. The patient would do the exact same as the Snellen chart. They would sit or stand, whichever one they're comfortable in, and the chart would be at 12 to 14 inches away from the patient. They would read top to bottom, left to right, down to the smallest line they're able to visualize. And the difference is that the reading for this test, a perfect score, would be 14/14, meaning 14 inches away from the client. And for the top number, and that 14 on the bottom would be what a person with perfect vision would be able to visualize. And again, that's for near vision. Then we're going to move on to peripheral vision, also known as confrontation test. We would ask our patient to sit down in this fashion. We would sit down in front of them, approximately 3 to 4 foot away. And we're going to ask the patient to cover one of his eyes, whichever one you like. And the nurse is going to cover the exact same eye. And you just tell me when you can visualize my fingers.
I can see.
And again.
I can see.
Alright, and we're going to switch. And again.
I can see.
And again.
I can see.
Awesome. And again, that's confrontation for the optic nerve. Moving on, still assessing the eyes, we're going to check for extraocular movement, and we're going to test cranial nerve number 3, the ocular motor nerve, cranial nerve number 4, the trochlear nerve, and cranial nerve number 6, the abducens nerve. And with this, we're going to look at the 6 cardinal fields of gaze. You're going to ask your client to look at a fixed object and just track with your eyes. Do not move your head. With this, he is able to track without moving. The eyes follow it with good symmetry. After that, we would check for corneal clarity. With this, we're assessing the corneas. And they are clear, they are symmetric, and there is no exophthalmos noted. So after that, we're going to do a cornea light test, and if you'll just look right at me at a fixed area and do not move. And with this, it's called a twinkle light test. We're looking for equal symmetry of lights in the eyes. If we did not see them, we could move on and do a cover and uncover test. This is going to check for the balance mechanism that keeps the eyes parallel in movement. So with this, I would cover one eye And if you could look at my pin light, and we're noting that when the card is removed, the other eye will track in the same movement as the first eye that was covered. And we're going to do the same on each side. If you'll look at this. And again, they are both tracked to the pin light. Now for a visual assessment of the eyebrows and the eyes. Looking at the eyebrows, they are thick, they are coarse, they are dark hair with same in line with the male pattern hair that this gentleman has. They do start laterally out from the outer canthus of the eyes and go in and become more sparse as they do semi-meet in the middle. Moving down to the eyelashes, they are thick, they do curve out and up, they are evenly dispersed. And if you take a look at me, just visualizing the eyes, the sclera is white, the conjunctiva is pink, there's no foreign bodies or mucus notated, the irises are brownish green. And as I'm palpating, tell me if you feel any pain.
No.
And here we're palpating the lacrimal sacs. And no tenderness.
No.
And I'm just going to take a look inside your eyes if you look directly at me. And here I'm notating the red reflex bilaterally in both eyes, visualizing the optic disc, which is about 1.5 centimeters in diameter. Notating that the pupils are equal, they are round. With the pin light, when I was moving them in, they are reactive to light. Also, when I'm visualizing, we're going to take a look at the fundus. It is creamy yellow. And no abnormalities notated. Also looking at the fundus, the arteries and venules are visible. They are in a 3:5 ratio and a 2:3 ratio. We're also looking at the macula, which is avascular and a light gray in color. Looking through to the center of the eyes, we're looking for the flovus interis, which is where the flow of visual acuity goes through. We're now going to move on to the ears, and I'm going to do a Weber and Rhines test to test for some symmetry of hearing. And if you would just sit straight with your head face forward, and you're going to hear a vibration, and I want you to tell me if it's on your left side, your right side, or if it's equal.
It's equal.
Perfect. And we're also going to move to this side so the camera can see. We're going to do a Rhines test. And do you hear that?
Mm-hmm.
And then we're going to place it on the mastoid process.
Mm-hmm.
And which one did you hear it more at?
In the front.
Perfect. So air conduction is louder than bone conduction, which we just proved by our client's answer. And that is the Weber and Rhines test. So just looking at the ears, they are even, they are symmetric, they are well formed. The curvatures are even, the pinnas are soft, they have good recoil. We're going to visualize the inner ear. And for an adult, we're going to pull up and out. For a child, we're going to pull down and over. And just looking in, there is a mild amount of hair. Very mild amount of cerebrum. The ears look clear. Visualizing the tympanic membrane. It is pearly white. It is not red or ruptured. Also looking at the ear, we're visualizing the inner and the outer ear. Looking at the umbus, the malleolus, the para, tens, and the parafascilla. I do also note mild blackheads on the inner aspect of the ear. Any tenderness in the ear?
No.
Any tenderness here on the mastoid process?
No.
Perfect. We're going to also test the acoustic nerve. I forgot to state that the Weber and Rhines test is cranial nerve number 8, the acoustic nerve, and we did that in the beginning. So I'm going to pan the room. And we're now going to assess your nose, if that's okay. The nose is a good shape and size for the face. It is midline. If you look up for me, the nares are equally patent on the outside. The septum is midline, no deviations. Mild disbursement of hair. Normal mucus patterns, no excess mucus noted. We are going to check for patency, and with that, if you'll cover one side and blow, and cover the other side and blow. Perfect, and the nares do seem equally patent. We're also going to test his olfactory nerve. That's the cranial nerve number 1, which is his sense of smell. So you would ask the client to close their eyes and have 2 very distinct different smells. So close your eyes. And when it crosses your nose, if you'll tell me what this is.
Pepper?
Perfect. And if you'll tell me this one.
Some sort of soapy scent.
All right, that's fine. And again, that was his cranial nerve number 1, the olfactory nerve. So moving down, we're going to inspect the mouth and the lips. The lips are moist, they are not dry, they are symmetric and midline with the face. If you would open up for me. And I'm just visualizing the inside of the mouth. I'm actually going to put my gloves on so I can palpate. And as I'm looking up in your nose, also notating the turbinates, the inferior ones are visible, but the superior ones are not able to be visibilized. Looking in the mouth still, the mouth is a light pink color. It is smooth. You have great buccal mucosas inside. Also notating the hard palate, the soft palate. And if you would stick your tongue out for me and go, ah. And with this, we're looking for the rise and the fall of the uvula, which is cranial nerve number 9, the glossopharyngeal nerve. And again, as he's going out, we're watching for the rise and the fall of that. And if you would stick your tongue out at me, stick it out, and stick it left to right. And with this, we're checking for symmetry, making sure that he is able to perform the task. This is cranial nerve number 12, the hypoglossal nerve. Speech and movement of the mouth is the vagus nerve, cranial nerve number 10, which he's speaking, he's talking just fine. I'm sure you eat just fine and swallow just fine.
Yes.
Also includes the gag reflex and swallowing.
The kitchen.
I'm sorry, I left my stethoscope in the kitchen. So now we're moving down to the thorax. And we're going to stand and visualize the thorax. I just ask that you breathe normal and comfortably. Ideally, the patient would have his shirt off to visualize the skin. We're going to make sure that there's no lumps, bumps, that the breathing is symmetrical, that the breast line is symmetrical with his breathing. And it does appear so. I'm just feeling for any murmurs or thrills. And I wouldn't see any heaves or lifts. So also, moving to the back, we're going to visualize breathing and just make sure the shoulders are midline, and they are. And if you would sit up for me just a little bit, or if you would stand, that might be a little bit better. Perfect. And if you would just say 99.
99.
And again.
99.
And again.
99.
And again.
99.
Awesome. So with this, we're looking for tactile fremitus, and you are going to feel the vibrations of the patient talking straight down the vertebral column and around. So we're going to fill down to the 10th, about the 10th intercostal space under the lung fields. And if you would take a breath for me. And we're just feeling for even rise and fall, even expansion. Awesome. So now we're going to check for diaphragmatic expansion. A normal test result for this would be 3 to 5. And if you would just bend over just a little bit and take a deep breath in and hold it. Awesome. And obviously it would be easier to percuss without gloves and without a shirt of mine. You would make a note, and then you would ask the client to breathe in again and exhale, and when you get to the end of your exhale, breathe. And you would percuss again. You would measure the distance, which should be 3 to 5 centimeters. Awesome. If you would take a seat for me. And now I'm going to auscultate the lung field starting in the back. If you would just take a breath for me, nice and easy. And another. And one more. And as we get down lower, just working our way to the outer aspect of the lung fields. All fields are noted to be even and equal. They are clear throughout. Any pain upon breathing?
No.
Okay. So we're then going to move to the front. And if you would lift your hands and just kind of put them on your head. And take a deep breath for me. And again. And with this, we're auscultating the lower bases of the lungs. You can put your arms down and relax. Take a deep breath. Moving down along the lower aspect, so auscultating all quadrants of the lungs. Awesome, and all areas are clear and equal. Moving down to the cardiac portion of our assessment, we're watching the chest rise and fall. We're looking for our PMI, which is around the apical area. You want a quiet PMI. You don't want to see bounding. We're going to start by finding our landmarks to listen, and we would start at the right intercostal space, about in between the second intercostal space on the right, and this is your apical. And then you move over to the left second intercostal space, which is your pulmonic. Moving down to the third intercostal space, this is Erb's point. Moving down to the fourth and fifth is the mitral, and then the tricuspid is down a little lower at the fifth. And the mitral is where your PMI would be. So we're listening first apical. And we're listening for the lub dub, the S1, the S2, making sure we don't hear any murmurs. And as I'm thinking, up here, the second intercostal space is the aortic. Mitral and apical are the same. Just to correct myself a little there. I'm now going to palpate all your pulses, starting with your temporals. And we're just making sure they're bilateral. They're not bounding, they're equal. Moving down to your carotids. They are also not bounding and equal. We're going to feel your brachial pulse and your radial. And again on this side. Your posterior tibial, your inferior tibial, and we could also palpate your popliteal pulse. And we're just making sure they're all equal, not bounding. Again, you could listen and make sure there are no bruits present, which are areas of turbulence and decreased blood flow. We mainly want to notate these in the carotids. And there are no bruits present. And with that, that is the end of our physical assessment. Thank you so much.
Thank you.